Okay, good afternoon, everyone. So my name is Jamie Colity, and together with Talani Stenefeld and Kiara Hershen, we will be presenting the topic of diabetes in primary healthcare, with an emphasis on diabetes within the time of the COVID-19 pandemic. So as Prof alluded to earlier, diabetes mellitus is of course a large topic for discussion. And we as a group really wanted to start it off with brief definition of diabetes. And as a way of introducing the topic, just glossing over the classification of the disease, how it is diagnosed, before moving on to more comprehensive discussions on the complications of diabetes, and really how importantly we can prevent and manage these in the primary healthcare setting, as well as how diabetic emergencies can be identified and managed within the primary healthcare setting. And then we really wanted to finish it off with a look at diabetes mellitus during the time of the COVID-19 pandemic. Is our screen fine? Are our slides coming up?
I don't think it's okay. Just give me a second.
It's slightly challenged, I think.
Something's not working here. Sorry.
Okay. There we go. All right. So
see it now?
Yes. Okay, so I just went over that outline and basically just discussed what we would be talking about today and what we're going to be focusing on, which is really our diabetic complications and emergencies in primary care and where our challenges lie within the management and prevention of these. And then we would like to end off with a pertinent discussion on diabetes in the COVID-19 pandemic and really how these two diseases affect one another. Next slide. So as an introduction, we would just like to define diabetes. That is a metabolic disorder with heterogeneous etiologies, and it's characterized by chronic hyperglycemia.
There's a bit of a delay with me changing the slides and it appearing on that side.
Okay, no problem. And disturbances of carbohydrate, fat, and protein metabolism, which results from defects in insulin secretion, insulin action, or both. So we just wanted to quickly gloss over the etiological classification of diabetes mellitus, which most of us know is divided up into type 1, type 2, other specific types, which really include genetic defects of beta cell function and genetic defects of insulin action. And lastly, hyperglycemia first detected in pregnancy or gestational diabetes. And really we'll be focusing mainly on type 2 diabetes because this is what accounts for 90 to 95% of cases, and that's where the primary healthcare focus is generally on. So this is just a slide that shows how the diagnosis of diabetes is confirmed, most of which many of us know this information. And we can use either a random plasma glucose, fasting plasma glucose, HbA1c, and those are the three that are most commonly used within the clinic settings, but we can also do a 2-hour post-load glucose measurement. So screening and diagnosis of diabetes is very important. And this is because many individuals may have mild or even absent symptoms, but despite that, their hyperglycemia can still be significant enough to cause complications, especially when this is persistent and undiagnosed for an extended period of time. So there are several challenges within the management and diagnosis of diabetes in primary healthcare. And these are the ones that we've really identified just from our own experiences. And they include certain things like lack of resources. So a lot of the time, our pharmacy actually does not have glucometers available for individuals at home glucose monitoring. And our allied healthcare professionals, such as dietitians and podiatry, is not always available on every days of the clinic. And then access to specialist care can be difficult in instances where you need to refer patients for complications and they have difficulty accessing the hospital. Perhaps they don't have transport or funds to get back to the hospital once they've been there. And then a lack of income to modify their diet adequately. A lot of the time we can educate individuals on what are the correct things to eat, but often a time healthy food is expensive, and to grow your own fruit and vegetables can also be time consuming. And then with regards to a lack of education, this is also not to say that the patients are necessarily not educated, but also to say that we need to work better on informing our patients of non-pharmacological and pharmacological glycemic control methods. Do patients know how to take their medication, when to take their medication? Do they know the impacts of diet and what they eat on their glycemic control? And do they know the importance of treatment adherence and the complications of not adhering to treatment or not coming to follow up? And then we also have the challenge of health-seeking behavior. So there are difficulties accessing local clinic for whether that be follow-up, treatment, and when patients have complications. And that's also been influenced by the COVID-19 pandemic, which we will expand more on later. So here's just a table, and it really outlines the main complications and how we in the primary healthcare setting can prevent and manage these. And the four main ones that we've looked at here are diabetic eye disease, foot complications, diabetic kidney disease, cardiovascular risk, and dyslipidemia. The three of us doing the presentation today work at Stretford CHC, and we have access to a podiatrist and a dietitian. But as we can see from this table, the most important prevention method for all these complications is good glycemic control. And as discussed on the previous slide, this can be through non-pharmacological and pharmacological methods. And it is up to us, although it can be challenging at times, especially when your clinic line is long and your consultation time is limited, to educate our patients on how to correctly take their medication and why it is important. But beyond that, there are other things that we can do: screening by visual acuity and fundoscopy, as well as annual foot assessments and educations on foot care and footwear. And there are certain blood tests and urine tests that can be performed in order to pick up certain complications early so that referral to specialists or allieds can be done timeously. And then, of course, we get the presentation of diabetic emergencies, for which there are two broad categories: hypoglycemia and hyperglycemic emergencies. Hypoglycemia, we do have the necessary equipment available often at the primary healthcare facilities in order to treat this. But hypoglycemic emergencies pose a bit more of a challenge, and it's mostly related to actually being able to correctly diagnose these. So we do at Stretford CHC, and I'm not sure if the other CHCs have access to this kind of equipment, but we have an iStat machine which presents its own challenges in that it often does not work, is dependent on temperature. And even then, the iStat cartridges don't always provide us with certain measures of potassium and sodium, which could make it difficult to accurately diagnose hypoglycemic emergencies in order to begin treatment thereof. And this is just the criteria used to diagnose those. So what can we do when we're presented with a hypoglycemic emergency at the primary care level? So rapid treatment is essential and should not be delayed. And of course, this involves confirmation of the diagnosis and initiating the following management. So there are things that we can do, and this is the recommendations from the Society of Endocrinology, Metabolics and Diabetics of South Africa. And it speaks of administering intravenous fluids, and as well as hourly boluses of 10 units of regular insulin IV until the patient is transferred. And then, of course, we can arrange transport to a specific hospital that is experienced in the management of these emergencies, whilst also providing clear instructions for continued management during their transportation.
Hi, this is Tilani Steeneveld. I'll be speaking a bit about diabetes during the COVID-19 pandemic and how these two diseases have impacted on each other. During our time at Barra last year, working in internal medicine department, and since working in clinics and district hospitals this year, we noticed a correlation between COVID-19 and diabetes, with many patients who were testing positive who were diabetic testing positive for COVID-19, and many patients who were presenting with diabetic emergencies also being found to have COVID-19 infection. So we decided to look at a number of studies which have been published, and some of these studies have suggested multiple pathophysiological mechanisms that may contribute to the increased likelihood of severe COVID-19 infection in diabetics. So in terms of the role of hyperglycemia, through the mechanisms listed, basically hyperglycemia limits the immune response in our diabetic patient, thus placing them at increased risk of infection. And then additionally, infection itself increases the body's insulin requirements, which can precipitate uncontrolled hyperglycemia in our patients. And specifically, COVID-19 has been shown to cause destruction of pancreatic islets through the binding of the virus to ACE2 receptors. So we're seeing that COVID-19 itself is precipitating uncontrolled hyperglycemia in patients who are pre-diabetic and in our known diabetic patients. So this is creating a vicious cycle of hyperglycemia pushing infection, and infection in turn pushing hyperglycemia. Additionally, COVID-19 has been associated with a lymphopenia, and studies have shown that specifically diabetics with COVID-19 have a lower lymphocyte count compared to people with who have COVID-19 without diabetes. Our diabetics have also been shown to have reduced lymphocyte functioning, as well as lazy leukocyte syndrome, which describes impaired phagocytosis. So these factors all contribute to impaired immunity, thus increasing the susceptibility to COVID-19 infections. There's been a significant link has been described between COVID-19 and the ACE2 receptor. So basically what we found is that COVID-19 seems to bind to ACE2 receptors, and through this mechanism gains entry into target cells. Viral replication thus occurs in organs that express these receptors, and these include the lungs, intestines, kidneys, pancreas, and blood vessels. And this can lead to a multi-organ inflammatory response precipitated by mass cytokine release. So for example, specifically in the lungs, these cytokines increase vascular membrane permeability, which can precipitate pulmonary edema and leading to severe COVID-19 acute respiratory distress syndromes. Our diabetics have been found to express higher concentrations of ACE2 receptors. Thus, these patients are at increased risk of a more systemic response to COVID-19. All right, next. So in terms of common presentations, a striking finding of many of these studies was the increased presentation of patients with DKA during the pandemic. This is something we have also noticed whilst working in internal medicine and various casualties. There was a point last year where almost every patient presenting with DKA had also been infected with COVID-19 at the time. Studies interestingly found that patients were also noted to present in DKA at lower plasma glucose levels than normal. Furthermore, studies have found that COVID-19, through the mechanisms mentioned before, specifically the destruction of pancreatic islet cells, seems to be unmasking newly diagnosed diabetics, with many patients started on treatment for glycemic control during their admissions to COVID wards. It is yet to be established whether the majority of these patients require chronic diabetic medication in the months and years to come post-COVID infection. So with all of the pathophysiological mechanisms mentioned, the factors listed on the slide have been associated with increased severity of COVID-19 infections, and thus resultant increased mortality rates. So specifically, as I mentioned before, hyperglycemia seen in patients with either suboptimal glycemic control or elevated HbA1c levels. These patients are more likely to develop severe infections. And also of note is that although raised in both, mortality rates are seen to be high in patients with type 1 diabetes compared with those with type 2 diabetes. All right, so what we could find from these studies in terms of what we can do now when managing patients during this pandemic, these are the current recommendation that these studies are giving. So basically, in terms of pre-infection and outpatient management for patients who have COVID-19 but are stable at home, the ultimate aim is to modify the factors that contribute to the severity. So this basically, the biggest aim is to optimize our diabetic control, as well as controlling the other comorbidities. And this can be done through reinforcing patient follow-up, encouraging lifestyle modification, which is necessary to focus on because a lot of this has been impacted by the lockdown regulations, as Chiara will be discussing, as well as to adjust medications as necessary. It is also important to screen for factors that may impede follow-up and adherence to treatment, such as anxiety and depression, the rates of which have also shown an increase during the pandemic. And if for our patients who have been diagnosed with COVID-19, our stable diabetics with COVID-19 mild infections who are managed at home, the early detection of potential diabetic emergencies and severe COVID-19 infections is paramount for these patients. So it's important to counsel them on the symptoms of these conditions and when to urgently present to casualty. And obviously this is limited by resources, but for those patients who have glucometers at home, it is important to encourage more frequent monitoring while they are infected with COVID-19. All right, so I'll go a bit on admission because this is something we can do in our casualties before referring to the appropriate facility for patients who have severe COVID-19 infections. The aim is to establish how well controlled our diabetics are. So we want to do things like HDTs, HbA1c levels on admission. And then we also would it's important to exclude the diabetic emergencies using urine ketones, venous blood gases. And then of importance and to note is that if our patients do have diabetic emergencies, before we transfer them or send them to the wards, it's important to give cautious fluid resuscitation because these patients are at risk of pulmonary edema caused by the COVID-19, and we want to avoid precipitating acute respiratory distress. In terms of the ward, so I'll go a bit about it. It doesn't really apply to us in primary health care, but the main recommendation, which can also be applied to outpatient management, is tighter glycemia control. So again, this can be done through the adjustment of medications as necessary. Often studies have shown that they've seen doctors transitioning from oral therapy to insulin or increasing the dosage of the insulin whilst patients are infected with COVID-19. And these patients also require more regular monitoring in the ward as well as post-discharge. All right, so when it comes to choosing the right medications for glycemic control during a COVID-19 infection, caution is recommended because it's important to consider multiple factors when choosing which medications to continue or to start in our diabetics. So these are important. It's important to tailor these according to the level of glycemic control, severity of infection, and the presence of complications in each patient. So looking at that table, it gives a nice display of which medicines to use in a mild infection with COVID-19 versus which might be contraindicated. So for example, metformin, which is very commonly used with our type 2 diabetics, It's actually been shown to have anti-inflammatory properties and is recommended for continued ongoing use in our diabetics with mild COVID-19. However, in those that end up getting admitted, although this isn't really pertinent to the primary healthcare level, but it's important to know, metformin has actually been associated with an increased risk of lactic acidosis in our more severely ill and dehydrated patients. And it's specifically contraindicated for patients with renal impairment, and COVID-19 has been shown to precipitate acute kidney injury. So that's just something we would need to watch out for. The table gives a good indication of all the other diabetic medications.
Hey guys, I'm Kiara. I'm going to be wrapping up and discussing the effects of lockdown in the context of a diabetic patient, as well as a summary of the diabetic consultation. So lockdown has had an incredulous effect on our lives, personally, professionally, socially, economically. It's really difficult to comprehend some of the daily struggles people are facing as a result of lockdown. So in order to contextualize, I'd like all of us to take a moment to just reflect on our own state of affairs during the past year and a bit. So at work, things have been really stressful, sometimes overwhelming. COVID traffic has been really high and individualized patient care, quite honestly, low. We've had experience working in clinics at a tertiary hospital and being given a stack of 10 to 20 files and just writing TTOs in order to limit COVID exposure. Sometimes with only the basic question, any new problems being asked, but even more often without an upward glance at the patient. Our notes say COVID-19 pandemic protocol, and we continue to push the queue. Countless non-emergencies have been turned away to come back when the dust is settled, and I think many of us find comfort knowing that we won't be at those clinics to deal with the influx when it has. In the wards, there have been questionable discharges in order to create bed space, people that have needed further rest, rehabilitation, and analgesia getting their discharge summaries signed. Others who are admitted for weeks on end haven't seen their families or heard from home due to the limitations in visiting hours. It goes on, and it's a lot to deal with from both our side and theirs. Then outside of work, it's been really difficult, both staying active, eating well. Personally, fast food has become a really close friend. I'm not even diabetic, not yet. So in most places, people are confined to closed areas where exercise opportunities are limited. They cannot take regular walks and visit gyms or swimming pools. And many communities have, pre-COVID, have had exercise and support groups that have worked quite well. Personally, I came from WITS, and we did community visits, and I visited a community and went to their exercise group, and it was really lovely. Apart from physically doing exercises, it was great support from the community, and just to think that that hasn't been happening because of COVID is a great loss. A body mass index, a BMI of over 40, was amongst one of the risk factors that are most predictive of the need for hospitalization during the COVID pandemic. And I don't think it's difficult to see that quite a lot, or a large number of our population does unfortunately fall into that category. Structured lifestyle interventions include at least 150 minutes a week of physical activity, and dietary changes are recommended to promote a weight loss of 5 to 7% in diabetics. Physical activity is really important because it improves blood glucose control in type 2 diabetics specifically. Aerobic exercise increases muscle glucose uptake up to 5 times through insulin-independent mechanisms. And as a side note, it also reduces cardiovascular risk factors and contributes to weight loss. So this is extremely important. Due to the unpredictability and social nature of the disease, mental stress is also great. Alterations in the daily routine affect dietary intake as well. So stress could lead to inappropriate eating. All these factors may lead to uncontrolled glycemia or worsening status of comorbid diseases such as hypertension, and predispose the patients to complications. The current pandemic and social isolation are likely to increase rates of anxiety and depression, as Tselani and Jamie both spoke about, which may also lead to poor adherence of medications and worsening of risk factor controls. people with diabetes have been shown to be more prone to mental health issues than the general population. And adherence to treatment can worsen when people are distressed or have depression. So while it's really frustrating to deal with a patient coming in with an HGT of 32, and it's almost unbelievable when they tell you, I took my medication, I've been taking my medication, it's important to be cognizant of everything going on in the background. And I hope this sheds some light on it. So what we can see in the slide, I hope that we can all relate to, or at least accept as something that has been limited by COVID lockdown. The decreased exercise, increased stress, poor dietary choices. I hope that everyone listening to this presentation can relate to at least those three without even being diabetic, and then all the rest as well. So in order to, well, in closing, this is a poster that we've prepared about a brief guide to covering the essential aspects of diabetic care in the primary healthcare setting. So this is in your consultation rooms. I mean, when we see people in emergencies that are coming in with DKA and with HGTs that are uncontrolled, sure, we don't really have that time to do a detailed foot examination. But when we do have the time, we need to make the effort to cover more than the first 2 points on this poster, which is generally what we do cover. So starting with the basics, this is something that we all do and that we all cover, the current HGT. So that reflects short-term glucose control, and that tailors our treatment adjustment, which is number 2. So if the short-term glucose control is inadequate, we tailor as necessary, and we discuss treatment adherence and side effects and allergies to the medication. So that's usually the scope of our consultation, or at least when clinics are busy, that's as much as we try to cover. But the rest of the points on this poster are equally important, if not more important. So number 3 would be education. So education, not just about diabetes, but about everything that comes with it. So you need to have ongoing discussions with these patients about symptoms of hyperglycemia and hypoglycemia. Not everyone has glucose monitors at home. If they have monitors, maybe they don't have strips at home. And maybe they just don't like pricking themselves every day. So we need to make sure that our patients know when they recognize in themselves the symptoms they're having could be because of hyper or hypoglycemia. Then lifestyle adjustments, we speak about this all the time, but stopping smoking, exercising for at least 150 minutes a week, the importance thereof. We need to keep educating our patients on this. Family planning, we know diabetes can have huge impact on pregnancy and the baby, so family planning is very important. Immunizations, I just want to take a moment in terms of immunizations. Every year we have our influenza vaccines, our flu vaccines that we encourage people to get. I know local clinics provide these vaccines, and it's great when you do get people to do that. But now we have a new vaccine on our hands, and that's the COVID vaccine. And there has been a lot of vaccine hesitancy in our local community, which I have experienced when interacting with patients. And I think it is especially important to educate our diabetics and, of course, everyone else that has comorbidities, everyone in general, but specifically diabetics, about getting their COVID vaccine. And because of everything stated previously in this presentation, it is imperative that they protect themselves in that way if they are in the correct state of health to do so. So if we do anything on this poster, please can it be educating our patients about getting their vaccines if they haven't yet. Then the last point on education, which has been covered before, is mental health. Screening for mental health, asking if they're doing okay and if they're coping, and if they have adequate support structures is really important. And I hope that that does translate in a consultation. Then the next point is something that I wish formed part of our vitals. You know, we get blood pressures, HGTs, pulses, SATs, and I really wish our weights, we could get weights as part of our vitals as well. We don't often weigh our patients, and we should. Diet and physical activity are the mainstays of self-management of diabetes. this is what the patient can do for themselves at home. And only when you have a weight to measure it against can you hold the patient responsible. If a patient has actually done really well, maybe they were a BMI of 40 and now they're a BMI of 37. I mean, slow progress is still progress. And we don't have any kind of record to show that. And then we just get frustrated that they're still overweight and they're not taking care of themselves. But meanwhile, they are actually trying. So when you get a chance, if there's a scale in your room, just document a weight. You know, we page backwards years and years of pages looking for information. And if we can just find a weight done every now and then, at least we can trace that. And it's really important. So weight, BMI, and waist circumference. Then on the face, we have eye examination and dental examination. So we should, at least on an annual basis, examine for dental caries and gum disease and do a visual acuity and retinopathy examination. And I didn't mention previously with weight, but we have our amazing allies to refer to. So if you feel like you in your consultation don't have the time, maybe that you don't have the equipment to do it, please refer on to the allies who do. So our dietitians, our dentists, optometry, or even ophthalmology if necessary. Then feet. Feet, also on an annual basis, it's recommended to do a thorough foot examination with monofilament assessment. So that is at least annually, but foot education should be happening at every consultation about foot hygiene, about foot sores. The sad reality is, in our consultations over the past year, where we aren't really examining our patients properly because of COVID, if we're even seeing them at all, someone could have had a little lesion on their foot. And now they're coming in a year later with a complete diabetic foot, and we're upset that they didn't come earlier. So please, ongoing foot care, and refer to podiatry or surgery as necessary. And then the last point is monitoring. I'm sure we all know everything about monitoring, but just to go over the guidelines, SEMDSA, the Society for Endocrinology, Metabolism and Diabetes, has recommended that at every 3 monthly visit, we do an HbA1c and urine dipstick. And at every annual visit, a formal glucose, HbA1c, lipogram, creatinine, and EGFR, potassium, HIV, urine dipstick, and ECG. So yeah, so just be cognizant of when last any of this was done for your patients. I know HbA1cs at Stretford are done quite regularly, which is quite nice. And urine dipsticks are as well, but just so we know. And I hope that has been really useful as an overview of how to approach a diabetic consultation. And if you have time for nothing else, just please, with COVID vaccines, and try and get everyone to do the right thing. Thanks, guys. This is our case example, which I think we'll be discussing next week. I'm not going to read it, and it has all the complications that need to be in there. I'll post it on the group.
See if you can send it to us in a Word form. It's easier to share. Thanks, guys. Let's just stop at that. I think Dr. Petkova, do you want to add anything to the conversation? Shall we move on?
I'm fine, Prof. Thank you.
All right, let's just get a quick rating of the presentation. And while you're putting in your rating there, I think thank you for the presentation. You guys always do a good job. We don't expect right and wrongs in terms of the way to do it. I think your individual take is fine. We do want you to apply yourselves creatively, and in some ways, these presentations are not just you teaching, but you also learning and us assessing how you respond to the sort of question of diseases in a particular setting, in primary care, and it's helpful to us. So I think everybody thinks it's a great presentation. Thank you for that. And I think this is true for everyone. When you are, so let me stop there, and you can just see your results. You should try and look at an individualized take on it. All these presentations are being taped, so you can always look at them again, and there are different takes on it. So it's all on the website, and I think that that is all part of your learning. So this presentation is not the only source of learning. Look at the other presentations that we've taped, including this one, in the future. All right, thanks a lot. Let's stop there. We are running a bit out of time. The other thing is to please keep it at 25 minutes. The presentation, just time it so that it does manage within 25. Thank you very much. Let's go to the next group, and we'll hope not to overrun time too long. So Dunisani, are you ready?